In chapter 27, we're going to talk about intrarenal disorders or disorders from within the kidney. And these intrarenal disorders occur primarily within the kidney, have a potential to result in renal insufficiency or even failure. And we can talk about some of the different causes of intrarenal disorders, such as congenital, neoplastic, infectious, obstructive, or even glomerular. And we'll give examples of each of these. The first type of congenital abnormality we'll talk about is renal agenesis or hypoplasia. Agenesis, A meaning lacking, genesis means to form, so agenesis means that the kidneys don't develop within the fetus. Now, this can occur either bilaterally or unilaterally. If it occurs bilaterally, this is not compatible with life, since you need kidneys to live. Now, if it's unilateral, what we find then is that one remaining kidney, because only one developed, can hypertrophy or increase in size to really just have all the function of the kidney entirely. So you have one good kidney that's also larger than normal. Now, hypoplasia means that sometimes kidneys fail to develop fully, and this can actually lead to pediatric end-stage renal failure. Now, what's nice though is that a single normal kidney can maintain normal renal function, and so you actually only really need half of the total number of nephrons to have normal renal function. But with this one normal kidney, it's going to require a lifelong kidney monitoring. Now, some other congenital abnormalities include things like cystic kidney disease. And cystic kidney disease is genetically transmitted, results in these fluid-filled cysts that can expand and disrupt urine formation and flow. These cysts can be localized to one area. It can affect one or both kidneys, or they can be sort of distributed over throughout the entirety of a kidney. This can lead to renal failure if there's enough obstruction, and if so, this can require dialysis or even transplantation. Now, this is what these cystic kidneys look like, and so this is a normal kidney on the left, and this is a cystic kidney on the right. And you can see that these large fluid-filled cysts here that can actually start to impinge on other cortical structures and really start to damage nearby nephrons and prevent normal urine formation. This is a more dramatic example. It doesn't always cause an entire organ to swell, but you're definitely seeing an example of a kidney that would be more of like end-stage renal failure because there's so much inflammation here that there wouldn't be a whole lot of functioning nephrons within this kidney here. And just keep in mind that it's genetically transmitted as well. Now, neoplasms of the kidney include things like renal cell carcinomas. It's a metastatic disease that can have familiar patterns, but some of the risk factors for renal cell carcinoma include things like smoking, obesity, and hypertension or high blood pressure. Unfortunately, with renal cell carcinoma, you'll see that it's asymptomatic until it's fairly well advanced. And this happens to be the case with a lot of kidney disease because you can actually function fairly well with half of the number of nephrons, that you won't get a whole lot of signs and symptoms until that kidney disease or even neoplasia is actually pretty well advanced. Once advanced, you'll see things like hematuria or blood in the urine, even palpable masses in the sort of lumbar area, thoracic lumbar region. Remember, the kidneys are located near the inferior ribs, so you could find a palpable mass near ribs, 10, 11, and 12. Now, there is a staging system to talk about what stage of neoplasia occurs, and we'll talk about that here in the next slide. The treatment for this is nephrectomy, or just removal, and the metastases for renal cell carcinomas are particularly resistant to things like radiation, immunotherapy, and chemotherapy, so the outcomes of renal cell carcinomas are more poor. Now, what this slide shows is the staging system, and we see, remember, it's a 1, 2, 3, 4 stage system. Now, stage 1 refers to the fact that this renal cell carcinoma has started to grow within the tissue of the kidney, but is still contained within the renal capsule, and it hasn't invaded any nearby tissue. So this would be a stage 1 renal cell carcinoma. In stage 2, the tumor has started to invade the surrounding tissue, and it's actually ruptured the renal capsule and could now be growing into like the para and perinephric fat around the kidney. Stage 3 is where the tumor has now not only invaded the surrounding tissue of the kidney, but also started to invade the tubular system of the kidney, sort of deeper, including the calyces and even including the hilum here. And at stage 4, renal cell carcinoma is where it is spread to other distant sites. So it's metastasized to things like your liver, the heart, lungs, bone. Really, any vascularized tissue could receive metastases from a renal cell carcinoma. Now, in terms of infection, normally our kidneys have these protective mechanisms that actually can prevent infection. Things like the acidity of your pH prevent infection because that acidic urine can help kill and wash out bacteria along the urinary tract. In men and women, there are bacteriostatic secretions, but for men, there's secretions that are made by the prostate. In women, there's different glands in the urethra that can secrete a protective mucus. And normal urination or micturition also helps to wash out pathogens. So, frequent urination helps to eliminate, bacteria and other pathogens from the urinary tract, and by washing them out, it prevents infection. Also, unidirectional urine flow prevents infection because if you don't have reflux, then what that means then is that you're constantly just sort of washing out that bacteria, which may actually be coming from, like the distal urethra. And if those bacteria are able to travel, backwards, back towards your, more superior portions of your urinary tract due to reflux, that can actually make you more prone to infection. So having unidirectional urine flow is an important protective mechanism against kidney infection or pyelonephritis. So pyelonephritis can be acute or chronic, and the most common cause of kidney infection is ascending infection from the lower urinary tract. If you're talking about bacteria that enter from the distal part of the urethra and then start to work their way back, that's the most common cause of pyelonephritis or kidney infection. But the one of the most effective preventative measures for patients that are sort of in a long-term care is more early removal of catheters and frequent replacing and changing of catheters. That way it actually prevents infections. So what this slide is showing are different routes of pyelonephritis or infection. We see that it can be either ascending or hematogenous. If it's hematogenous, that means it's coming from the bloodstream. We know that our kidneys receive a pretty large portion of our cardiac output, and if there's bacteria in the blood, so if we have bacteremia, they could travel in the bloodstream and deposit within the kidneys from the blood itself. Some of the more common agents of this hematogenous infection of the kidneys include things like staph and E. coli, where once in the bloodstream can particularly deposit in the kidneys, and that can lead to more sort of widespread infection of either one or both kidneys. Now, ascending infections can come from different normal microbial flora that can ascend from the urethra into the bladder and then up the ureters, which then could eventually get to the kidneys themselves. Now, what we find then is that if unidirectional urine flow is present, then it would prevent this ascending infection. But if there's reflux of urine due to like the failure of valves or paralysis of the smooth muscle in the ureters, then urine can start to actually work its way back up, and that ascending infection could eventually lead to kidney infection. So when you're talking about urinary tract infection, cystitis, or bladder infection, that could eventually lead to kidney infection by moving in a sort of ascending pathway. Now, acute pyelonephritis is where you have infection of the kidney, and it usually comes from an ascending UTI. One of the major risk factors for acute pyelonephritis is pregnancy, because with pregnancy you can get some extrinsic sort of pressure on the ureters and the bladder, which can make it more prone for reflux of urine, and having that sort of dirty urine work its way back up into the ureter and kidney. Now, the diagnosis of acute pyelonephritis is fairly simple in the sense that if you find white blood cell casts or cloudiness of urine, this is indicative of upper UTI, because these casts will form within the structures of the ureter or even the kidney itself. And basically a cast is white blood cells that take on the shape and form of basically urinary tract structures. Now, with chronic pyelonephritis, it can result in chronic kidney disease, and it's usually associated with reflux or obstructive processes where you have persistent urine stasis, or sort of where urine's not moving frequently. This chronic inflammation can lead to things like scarring, as well as loss of functional nephrons. You know, if it infects the kidney, and like it's saying, this can lead to chronic kidney disease from just pyelonephritis, basically kidney infection. Now, obstructions can also lead to renal disease, and these obstructions are just basically any condition that interferes with the flow of urine. It can be congenital or acquired, and so there are different changes that can result from the type of obstruction, whether it's partial, complete, unilateral, bilateral, as well as the duration of and timing. Like, is it an acute obstruction? Is it a chronic obstruction? And the sort of mixture of these can tell you about the progression of the disease that can follow. Now, obstructive processes cause urine stasis, which then can make someone at risk for infection. Now, what this slide is showing are some of the causes of different obstructions. You can see here that we'll start with the urethra. So we can find that we can have valve strictures or narrowing of valves. Tumors of the urethra as well can lead to obstructions. And if these prevent normal urine outflow, then that can lead to urine stasis and make someone at risk for infection. What we find is that in males, prostate hyperplasia or growth can also start to occlude or narrow the urethra here. And that can also make someone at risk for infection due to urine stasis. In the bladder, the presence of calculi, or basically, little tiny calcium deposits, tumors, or even neurogenic causes where you might have bladder paralysis from nerve damage. All of these can make someone at risk for infection, and this is just a different type of obstruction. Now, what we find that is that if someone's ureteral valves are failing, this can actually also be an obstruction in itself, where urine can start to back up in the ureter here, and that can lead to infection. Now we have intrinsic and extrinsic obstructions that can occur too. Pregnancy, tumors, retroperitoneal fibrosis. Any of these can start to sort of protrude on the ureter externally or extrinsically, and that itself can obstruct normal flow. Intrinsic obstructions can come from calculi, tumors, clots, sort of sloughed tissue from papilla, or even inflammation itself can lead to an intrinsic or sort of obstructions from within the ureter here. Otherwise, within the kidney, what we find is calculi, tumors, or even strictures can also prevent normal urine outflow from the kidney. Now, glomerular disorders are also called glomerulopathies, and these can alter normal glomerular capillary structure and function. Now, this damage can be either immune or inflammatory mediated, and therefore could be like hereditary or environmental. Now, it can be caused by metabolic disruptions, infectious agents, hemodynamic disorders, toxins, genetic diseases, or even injury itself. Now, what this next slide shows, though, are some of the sequelae or consequences of nephrotic syndromes. So nephrotic syndromes, what we find then is that due to damage of the glomerular membrane, we see increased glomerular permeability. We know the glomerulus normally prevents against larger substances from leaving your bloodstream and entering urine. So with this increase in permeability, what we can find then is that we can start to lose protein from blood into urine. And proteinuria, or protein in urine, could lead to hypoalbuminemia. We know that albumin is one of those plasma proteins that helps establish our plasma osmotic pressure. And if we're losing albumin into urine, this can lead to low albumin in the blood, or hypoalbuminemia. Now, hypoalbuminemia leads to a variety of disorders, or sequelae. So we see here is that due to loss of albumin, we could see a decrease in plasma osmotic or oncotic pressure. This can lead to a decrease in circulating blood volume due to loss of plasma into your body's tissues. This loss of plasma into tissues can lead to generalized edema, like all over our body. Now, due to a loss of plasma volume into your body's tissues, this can also lead to the stimulation of the renin-angiotensin-aldosterone system due to a decrease in blood pressure. And this stimulation of RAAS also causes a retention of sodium and water from the activities of aldosterone and antidiuretic hormone. And because these hormones promote the reabsorption of sodium and water, then that can also lead to more edema formation. So what we find is that from the loss of albumin, not only can't you hold on to your body's plasma and you lose that in your body's tissues all over, causing generalized edema, but it also decreases blood pressure sufficient where you also start to retain excesses in sodium and water, which also promote more edema. So that's one of the sequelae, is generalized edema from nephrotic syndrome. One of the other consequences is that due to low albumin in the bloodstream, this causes an increase in basically liver activity. And from increased hepatic synthesis, what we find is excesses in clotting factors and lipids. And so from clotting factors, what we can find then is that someone can actually have clotting disorders in response to nephrotic syndrome, or hyperlipidemia, where we actually have too many lipids in the bloodstream, and this can actually lead to the progression of atherosclerosis from that proteinuria. So these are all the interesting sequelae that come about from increased glomerular permeability from these nephrotic syndromes, which are basically damage to the glomerular membrane.